So again, thanks to everyone who helped organize this and for this opportunity for me to speak about a topic which is really important to me, this intersection between hunger and health and what it means to the practice of medicine and to our communities. So I'm going to say a word about research. There it is, a word, research. I've been really fortunate in my professional activities to be very involved with this issue of research about childhood hunger when I first started out 15 or so years ago, and now food insecurity. The terminology has changed, and that in itself has posed some challenges in definition and in talking about this topic. And there's been a lot of talk about research already. I just want to kind of give just a very brief overview that my view of this body of research, which is now 60, 70 good articles that are in peer-reviewed kinds of journals and really solid evidence that of three things, I think, that the research has been focused on. And I've been very proud to be a part of this. One is that hunger exists, and that is where we have to start. And I think somebody asked the question, why is it taking so long? I think it's because it's not visible. I cannot look at a child that I see in my schedule of children that morning and look at that child and know they are hungry. And neither can their teacher. And I think as a society, we're very blind to food insecurity and its significance. So first we have to say it really does exist, and USDA figures say 20% of families with children. That's the most recent figure, 1 in 5. The state is, much like Colorado, 14.5% families with children, food insecurity. My clinic, where we've been surveying hunger for 15 years now, average 36%. More than a third of the families that I take care of are really in this box of food insecure. So that's something that I really need to think about. I'll maybe come back to that. One, it exists. Two, that it matters, that it has health consequences, and you've heard some of them: anemia, developmental delays, hospitalizations, obesity, low birth weight, on and on and on. It matters. There are health consequences, and these are good studies where other factors have been controlled for to the best of our ability, and we show health insecurity in and of itself contributes to poor health outcomes for children, for adults. And number three, that public policy matters. And a word about public policy. You know, I think really the question for us is 69% of those eligible are participating in SNAP. That doesn't compare terribly favorably to other states where the average is about 75%, honestly. And the question for our state should be, what's it going to take to get 31% more people signed up? What would it take to do that? If we could do that in 6 months, how could we change healthcare? So I would put that out to you. But the other thing I would put out to you is that our research shows, and my clinical experience shows, as I know Sandy's with, is that families who are on SNAP are experiencing food insecurity too. And that our public policy, we know the medicine, we know the dose isn't enough. So when I treat strep, I want to give an adequate dose. When I treat hunger, I wish I could give an adequate dose, but public policy doesn't always allow me to. And we need to really fortify this program, WIC, SNAP, to make it do what it needs to do. We're presenting in 3 days at our national meetings in Vancouver, our international meetings, data that shows when the increase in food SNAP went up as part of ARA, that food insecurity improved, but over time that deteriorated as food prices went up. We are not really providing enough of a benefit. Enough said. So how did I move from research to some of the programmatic stuff that we have been playing with across the river at Hennepin County Medical Center? So as part of the research, we began to do a food stamp nutrition education program, and we were giving samples of food. We were giving canned food because one of our messages was that canned food is a healthy, low-cost alternative, and have you tried them? And we were working with a population, some of which that was a little distrustful of canned foods. So we started to realize, if we partnered with the food shelf, we could get more samples. So that kind of led us down the road, and one thing led to another, and led to another, and led to another, and soon we were developing our own hospital-based food shelf, which we call the Therapeutic Food Pharmacy. We wanted to put it in a medical context. That's why we named it this kind of term. I'm not sure we're going to stick with it. I don't always love using it, I have to say. But this is a hospital, clinic-based food shelf. We are providing nutrient-rich food, and we do make decisions about what food we allow or don't allow. We try to provide it with nutrition education. Those families who are accessing it are referred by a clinic staff. Just to throw a little provocative piece out of there, it was my personal feeling that as a physician, I did not want to gatekeep the ability to access this. I did not want to write a prescription for food. That bugs me. And so that is not how our program works. It can be referred by any staff member, including the clerks up front. And at the same time, families are offered other community resources, including WIC and SNAP. As I will talk more about this particular program, but let me introduce you to another program that we've played with in our sandbox, and that is the Summer Food Service Program. This is the federal program that provides summer meals to children 18 and younger. It's a USDA federal program. It's administered through the Minnesota Department of Education, interestingly, and we see this connection between education, nutrition, and health. We've been able to provide breakfast and lunch to children in our cafeteria over the summer, Monday through Friday. We're in the process now of planning our 5th summer of operation. In 2013, we're reimbursed $1.94 for every breakfast we serve from the federal government, and $3.41 for every lunch. We were paid a total of about $8,500 for providing the meals we provided. And so it was a financially break-even endeavor for our institution. It requires the wonderful willingness of our food service director, Bill Marks, who's been a wonderful champion for me in both the food shelf and the summer feeding program. We are no longer the only hospital-based site in the nation. Little Rock, Arkansas Children's Hospital began last summer, really based on our model and my collaboration with a pediatrician there. So another way in which a healthcare infrastructure became involved in this. Who have we served? Well, the summer feeding program, last year we served about 2,800 meals. And our income eligibility for the food pharmacy is less than 200% of the federal poverty level. Over the years that we've been in operation, you see this rather rapid increase in the number of households we've served. Last year, in 2013, we served getting close to 24,000 households. We believe that represents about 75,000 individuals, and we've distributed about 850,000 pounds of food in our clinics. What are our sources of food? Very heavily we rely on Second Harvest Heartland. We also use TFAP commodity foods. We access the Emergency Food Network. We do some food rescue from local grocers and bakeries. We do some food drives locally, and we also have benefited from other ones that have then been distributed to us. And in the summer, we have some access to surplus garden donations. So let me tell you a thing about our food shelf. Which is a little different, is that as I attempted to initiate this endeavor, I immediately hit a wall because there was no space for it. There is no space. And I came to accept and believe there is no space. So it wasn't going to happen unless we found a way around that. And what we found instead is that there were little small spaces in corners. And we assembled, we have a virtual space in many different places. Sometimes I like to say, I can't tell you where we store the food. I would have to kill you if I told you. It is highly guarded information. So we are decentralized. And part of that storage is in our nutrition services. Again, thank you very much, Bill. But it is in other places as well. We are decentralized. We have some larger area for larger storage now, but our model is not that clients come to us. It's that the bags are assembled separately and they are then distributed to clinics. We're currently distributing to about 20 different outpatient clinics in our building on the HCMC campus. We also distribute to 4 outlying clinics, and we provide bags to the EMTs to have on their runs. We also have staff available by pager. If we get a page for a client who's someplace else, we'll try to fill that need when we can. And some of the bags are individualized. In pediatric clinic, we have more child-friendly food. In diabetes clinic, we've been careful to work with their nutritionists around what do they want in their bags. It's been an opportunity to kind of individualize. In our operation, volunteers are essential. That first is a picture of them slogging through snow, transporting the bags that they've created to another part of the campus. We try not to do that, actually, very often. But they really are important. And as has been pointed out earlier, hospitals are a place where volunteers are valued and encouraged, and it's an opportunity to interact with our community in ways that are really important. And the food shelf has been a venue for that. There's already been some discussion about, why healthcare? Why us? Why healthcare? And I think many of these have been alluded to. I want to say maybe one thing that hasn't been alluded to, in addition to what exists in a healthcare setting, and this was a learning for me. Something else that exists in a healthcare setting is it's a big base, and in some communities, the largest employer. There are a lot of people who work in health centers, and you know what? If you do an analysis, some of those people are food insecure. This is one of the reasons why Bill has been, I think, supportive to some of my efforts, is he realized the irony of the employees that he supervised working in distributing food to others who went home and were hungry. And so I put that out to you as another thing to consider. And the flip side of it is, what does it mean to healthcare organizations to have healthy employees? So I have to admit I was a little bummed out when I realized here's our flyer that says food is medicine. Bill had those made up, and I loved it. And then I realized we're really not the first to come up with this. We're not the first. This sort of predates my time in medicine. So what can you say? So looking back, this has been commented on, but I think we still have a message to carry forward. Looking back, let's look forward too. What am I looking forward to? What am I thinking about? I think about a couple things. I think about my own patients. I think about I was in clinic last night. I'm going back to do clinic today. When I look at that 5-pound baby, when I take care of that kid who's been hospitalized for pneumonia 3 times, and the asthma just isn't under control, and the medications are not doing what I think they ought to be doing, but maybe they're not getting delivered the way I'm intending them to be delivered. Or when I think about that overweight kid whose cholesterol is going up and who's pre-diabetic, when I think about that kid who I'm writing a prescription for Ritalin for ADHD, and I need to be asking myself, how much is food insecurity influencing their health? And I'm seeing it expressed in these ways because there's evidence that all 4 of those kids could be impacted. So I think about how do our efforts to do this impact the clinical care that I provide, that many of us provide. I think about the issue of disparities because we know, and thank you, Ed, for your help in us trying to communicate that we are not going to make progress in changing the health of our nation, and we are not going to make great progress in decreasing the cost of health care until we use that lens of disparity. And we say we need to address disparities, and food insecurity is a big disparity. And I think about what is the hospital of the future? I grew up watching the Jetson, and I hope jetpacks are part of it for the physicians. But even aside from jetpacks, I think as we move from treating disease to preventing disease to promoting wellness, that's where the hospital of the future needs to reside. And a big piece of that has got to be nutrition, and nutrition has got to be about ending food insecurity. And so I think these kinds of conversations are so important. I think that place of the future is about physical activity and access, not just for those who can afford a membership to Lifetime Fitness, but access to all, to healthy physical activity. I think it's about access to patient education and to mental health services. We have to have a vision for what this hospital of the future really looks like, and I think nutrition is going to be core to that. So with or without jetpacks, I'm looking forward to this kind of future, and I hope that you all are too and excited about the kinds of collaborations that can happen. Thank you.